Welcome, folks from around the world. I am Tom Stewart. I'm Chief Medical Officer here at Deloitte. We have a room of about 60 here in Toronto right now. We have people calling in from across the nation as we speak. There is about 800 registered for that. And then we have an office in BC right now that is meeting and zooming in for this, and they're also having a discussion around primary care. So excited to see everyone, and I'm really happy to hand it off to my friend, Dominic Nowak, who is not only a great guy, he's incredibly humble, does a lot of different things, which I was just explaining to this group here. He is on faculty at University of Toronto. He's head of family medicine at Women's College Hospital, which is represented here in the room. He is the recent past president of the Ontario Medical Association, which is one of the world's largest grouping associations of physicians in the world. And Dominic, I've met him over the past handful of years. He's just an incredibly humble and well-spoken guy. Dominic, I'll hand it over to you to introduce the panel.
Thanks, Tom. So I have a mic. Can you hear me okay? All across the room. We have some amazing panelists joining us today, but they're coming in from all around the world. As my own icebreaker, if you had to share one word that describes our healthcare system here in Canada for our international panelists joining us today to set the stage for their conversation, what's a word you would use? Sarah, why don't you start? One word: sick, siloed, underfunded, sclerotic. Give us some more words. Overly politicized. Let's get a few orthodoxies. And we just had some orthodoxies here that folks were sharing. Let's get a few more. Tell us about that. Possibilities and potential. Give us a bit more about that.
We have a lot of opportunities for innovation, a lot of phenomenal minds in the room and exterior. I think we have a mission, we have leadership in primary care governments. I think we're at a point post-COVID where there's a lot of momentum where we can dive into a lot of different ideas that we've all kind of talked about in small circles. And I think funding is there too.
Yeah.
But I think we can do better.
Yeah. So there's hope. What we're hearing is that there's hope and we have the right people and the right mix of conditions to get something to change. And for those of you joining online, for context, we have probably every single person in this room, and probably many of you online, could be on this panel, right? There's such a wealth of expertise and knowledge here. I'm looking at many of you who are involved in shaping our healthcare system all the way across the province and across Canada. And with that, why don't we open it up to our panelists? So panelists, as you're sharing, briefly, help us connect with you. This is not your main share. I'll ask your main questions next. Give us around 30 seconds to a minute of your why purpose for how you landed where you landed and what brought you there in the first place. So Dr. Alex Dobranowski, former national, international athlete, track athlete, doctor, AI technology president. Why don't you start us off? What's your why story for being where you are today?
I liked your opening question, right? Let's describe Canadian healthcare in one term. And I think the first few adjectives used, right, were let's say weren't very optimistic sounding. And I think we all have, we've had experiences, right, either with loved ones directly or personally, right, which has kind of driven us or has provided us with the passion of what we want to do. I think what really kind of drove a big decision I made, which was to leave clinical practice and work basically full time, first as an entrepreneur, but really focused on technology, was witnessing firsthand the kind of budding technologies now, 10 to 15 years ago, that we were starting to see some evidence around showing, and this is in particularly in medical imaging, which is my background, but it was showing the strength of some of these technologies being, 2 magnitudes more accurate than the human trained radiologist. And that's pretty incredible if you think about it. And, just taking a quick step back, right, we a lot of interesting dialogue around autonomous driving, et cetera, and how much safer it is. at some point you'd think, okay, well, these software systems, it would be inappropriate for humans to remain behind the wheel. For certain areas of medicine, we may actually gravitate to that kind of an outcome. And I think that's part of, evolution. So witnessing, the effect and development of some of these technologies was really something that inspired me. And then there's also, other kind of personal experiences too. But I'll hand it off to the next panelist.
Thank you, Alex. And as you're hearing these answers and where folks are coming from, how they relate to Canadian healthcare in their own leadership roles internationally, we'll have people running around with mics in the room. So raise your hand in between some of our questions. And then online, we'll be taking in questions, reflections, ideas that we'll share with our panelists as well. So next up, let's go to Dr. Karen Kirkham. Dr. Kirkham, you've been, as they call a GP, or as we call a family doctor here in Canada, for over, 30 years? Mm-hmm. And you've led transformation, integration in the NHS. And now you're Chief Medical Officer for Deloitte, and you get to look at healthcare systems from all around the world and see what's working well, what's not working so well, and advise them. What's your why story, briefly in 1 minute or so, for how you got into that?
Okay, thank you. And it's a pleasure to be with you, and thank you. So being a doctor for 30 years, and I guess I really want to go back to what that meant to me. So, I practiced family medicine in the heart of a community, which was more about medicine, and much more than just about medicine. It was about being, someone who was really invested in that kind of heart of a community, which is, I think, what general practice really is as a family doctor. But it offered me the opportunity for not only cradle to grave medicine, rewarding patient relationships, intellectual variety, portfolio working, which I was able to, scratch that itch of, real interest. And that led me to leadership and management at a local system and then at a national level within the National Health Service. And I think my role just coming here then has just been an accumulation of all of those little backstories and all of those, those projects, those things that I guess, tried to make things better within my local and national role. And so I think we are all a product of our backstory. And my backstory is very much be a good doctor, think about improvement and innovation, and then help lead others. And that's kind of my backstory. So I work now as CMO within the UK firm and have a global role, as you say. So I have the huge opportunity to learn what's happening internationally and bring that to the clients that we work for within the firm. So thanks for having me.
Yeah, thanks for joining us. Let's go to Dr. Mirja Sjöblom next. So senior economist with the World Bank. And Mirja advises countries' health systems internationally and how financing works in their healthcare system and how to finance well and what doesn't work as well. So Mirja, tell us about your why story. What got you to where you are today?
First of all, I want to thank you. Thank you, Deloitte, for inviting me. And it's really a pleasure to speak to all of you in the room. So I've been thinking about that question, and it really took me back to a time in my life quite some time ago. After my second year at university, I was studying economics and finance, and I wanted to learn Spanish really fast because I had been awarded a scholarship to study at the Spanish university. So my idea was to get to live in a family that didn't speak English nor Swedish. And through sort of a twisted turn of events, I ended up in Guatemala. And I was helping to run a daycare center for children whose parents were working in the city's garbage dump. And these children were really hungry, they were very sick, and they needed a lot of love. And I was shocked. I was shocked that this society had failed the most vulnerable so completely, and that they weren't even provided with the basic healthcare, something that I, as a Swede, had always taken for granted. And in that moment, I also realized something important, that I could not fix this alone. I needed to work with the people who made the decisions about the resources in this country. And that experience really changed my path. And for the past 20 years, I've been working with governments and also done research on different healthcare systems. I've worked in Africa, in Latin America, Europe, and Central Asia, and I also done a lot of work on the Swedish system, and that's what I'm here to present to you today. So yeah, that's my story. That's why I'm here. Thank you.
Thank you, Miriam. And last but not least, Dr. Jay Bhatt, doctor, public health expert, enormous amount of work in health equity and leading the Deloitte Center for Health Solutions. Jay, tell us a bit about your why story. What sparked you doing the work you do today?
Sure. Thank you so much. It's just so incredible to be here with this community and so grateful. Thank you for having me. I'm the son of two South Asian immigrants. My dad, a pharmacist on the south side of Chicago, my mom, a factory worker. And I spent a lot of time growing up in people's homes who had to make very difficult trade-off decisions about whether it was health that day, whether it was their kids that day, whether it was food that day, whether it was housing. And that gave me a real interesting perspective on the challenges that people face when it comes to being healthy and managing that health. And when I was in college, I worked with some doctors who put a clinic in the back end of a barber shop. Said, if you want to get your hair cut for free, then you'll be seen by the doctor. And it brought people close to community, to where they felt comfortable. And that community then shifted to not only becoming better from a health perspective, then they started helping each other get jobs. Because if you don't have economic mobility and opportunity, you don't have health opportunity. And so for me, that taught me that I wanted to really focus on doctor and underserved communities as a vehicle for social change, as a primary care doctor and geriatrician now in a community health center in Chicago, and to lead large systems change at scale to help communities change their future. And so I've had this journey of working as a managing deputy commissioner, the Chicago Department of Public Health, working with health systems, community-based organizations, and our public health system and government to drive better health for our city. And then with the Illinois Hospital Association and American Hospital Association, helping as chief medical officer, health systems drive a better healthy future for the people they serve and meet their mission. And now at Deloitte, leading research and insights and working with our client teams in advancing whole person health and a perspective that, it's wellness and health that we are focused towards, and that systems need to support that, incentives need to support that, and we have to reduce the fragmentation and create the kind of ecosystem of communication, collaboration, integration to improve health outcomes, reduce costs, and enhance the experience of both patients and caregivers. And we know that nearly 80% of health outcomes are impacted by social, economic, genetic, environmental factors. And so we've got to think about that in the course of our work. So glad to be here. Thanks so much.
Well said, Jay. Remind us where you're calling in from.
Chicago.
Chicago, from the great nation state
Yes.
of Chicago. The first question goes to Dr. Karen Kirkham. Karen, anyone in the room been following what's going on with the NHS recently? So new 10-year plan. And I will say, I read this plan a few days ago. They called the NHS in critical condition. People can't find a GP, or again, as we call them here, family doctors. Wait lists are ballooning. Staff feel demoralized. There are big challenges in access to care. They called out lagging indicators for cancer care and so much more. They called the NHS at an existential brink. They said, I quote, they have the choice or to reform or die. And how many of us can relate to that here as well in our great nation state of Canada? So Karen, what's that all about? And what's the thinking of how do we restore morale and support to a workforce that feels like they do here in this report and in the 10-year plan?
Thank you. Yes. Workforce are our biggest asset, and they stay with us, don't they? The doctors that work with us often for a lifetime. How do we keep them in the workforce? So I thought I might just, if it's okay, for people who maybe haven't read the report from end to end, I thought I might just do a little brief background into what those trends are going to look like over the next 10 years. I recognize the words that just came from the room around how other healthcare systems are feeling. And I think that some of what I'm going to say will be very replicable from, in many other jurisdictions. So the salient points about the evolving plan in the NHS there are three shifts. One is analog to digital. The second is from sickness to wellness and to prevention. And the third, and I'm really excited about this, is a shift out of hospital, where the most expensive care setting is, to community and primary care settings. And it aims to revitalise general practice, increasing numbers, reducing administrative burdens, implementing new care models in quite a different way, with a couple of new contracts that are planned. One is around single neighbourhood providers, so going away from perhaps the more traditional GP partnership model into around 50,000 people as a single neighbourhood provider, and then some multi-neighbourhood providers looking after around 250,000 people. So you start to get the scale and the ambition that allows us to think differently about the way that we deliver care. That is not to say that all of the traditional GP practices are going to go. It's just saying that there is a movement to something that looks quite different. And the goal is a neighbourhood health service which incorporates everything from prevention, genomic data, digital tools by 2035 to enable real personalised predictive care. And I think, as I say, this creates a huge opportunity for us to reset the care models and describe the skills which are needed to support delivery. So workforce, current and future needs will change, and we need to do a few things. We need to train and retain as a critical aspect of what we're trying to do, whilst we understand the changing needs of the population, the changing service, the changing workforce, and then recognise the impact of that kind of accelerating trend to the use of digital and data. So in raw figures and themes in the UK, and I'm just going to give you a UK kind of vision, we've had a critical workforce shortage in general practice for over 10 years, severe shortage of GPs, nurses, pharmacists, and we know that we've probably got around 16% fewer qualified GPs relative to the population compared to other high-income countries. We've got specifically a reduction in partner GPs, so those who are owning practices, compared to salaried doctors who don't own partners, who aren't the ownerships of the partnerships, but they come in and do the clinical work. So we have sort of a change in the way that GPs are choosing to be employed. And there's been a steady increase in the number of patients per full-time equivalent GP, offset slightly by a very determined view to improve and increase diversity within teams, so multi-professional teams. So what's happened in the UK? Significant investment is being made to expand the number of training places for doctors, nurses, and other healthcare professionals that's been in train for some time, including university and medical school places, expanding apprenticeships, and so on and so forth. And the government has announced its intention to publish a new 10-year workforce plan. So we've got the 10-year plan, we now need a workforce plan to reflect the changes which are expected from digitalisation. It answers some questions about what workforce do we need, what should they do, where should they be deployed, and what skills should they have? And of course, that will look quite different with the thought about the move from analog to digital. So we expect probably a slightly smaller workforce than is projected in the original plan in 2023, but with a real focus on staff being better treated, more motivated, better trained, and having greater scope for career development. I just want to pop a slide on the screen because I've just done a bit of research thinking about the future of primary care. We did a lot of interviews with GPs on the ground and their staff within the UK. And you'll see there's some real, we did some sentiment analysis, and on the left, I think it'll be the left on your screen as well. This is how they felt today: challenged, confused, broken, like some really, misunderstood, some really negative sentiments with workforce shortages, overworked, lots of stress in there. And then we asked them, in 5 years' time, what do you think it will look like? And on the right, this is what they came up with. Very optimistic, proactive, personalized, community-centered, fit for purpose. I think people are really up for a change in the UK, and I hope that's replicated elsewhere. So we'll take that down. I'm happy to share it afterwards. So there have been some changes too in the way that GPs in the UK work. So the average GP now works on average, this is an average, around 6 sessions a week, down from 6.6 in 2019. We've seen also an increase in the hours per session, which is now an average of around 6 hours. So longer sessions, fewer sessions, condensed working, and partners tending to work longer than their salaried colleagues. And interestingly, over 60% of GPs in the UK reported to undertake some form of non-GP work. So although the actual GP headcount has been gradually increasing, the number of full-time equivalents has actually declined since 2015. And we know that GPs are managing their stress by reducing their working hours. And if we want to improve access, we need to find a way to lower that GP stress, enhance job satisfaction without reducing that availability of appointments that this might represent. And I think the other thing that came out in our analysis was I noticed a real difference in staff motivation at different stages of their career. So if they're in the first 10 years, second 10 years, or third 10 years, although some things were the same, work-life balance was really important for early stage GPs, whereas making a difference, working in a team community was more important for later stage GPs. So I think it's really important to kind of understand what motivates people at different times of their career. So that's a little bit about training. Second is about retention. So we have to retain the people that we train. In England, we think that the financial cost to the public purse for losing and replacing a single experienced NHS GP has been estimated at a minimum of £295,000 per GP we lose. And it costs us around £500,000 to train a GP from beginning through the 10 years that it takes to get them out the other end. And then with a worrying trend of around 40% of GPs across the UK saying it's unlikely that they would be working in general practice in the next 5 years, government investment into GP retention through mixed approaches is a cost-effective solution to safeguarding the NHS, and indeed is a priority if we want to improve patient care. And the Royal College of GPs in the UK has called for a national retention strategy that ensures national consistency and leadership. And then there are a number of schemes that are already in place, such as supporting new to practice, making sure that new GPs coming into the system are able to be supported in the first few years to help them stay in what is actually a really difficult career. And I think none of us would say it's any different. The risk we take is really huge, and we've got to make people feel really safe in that role. And then a few other ideas around ways to keep people in the profession is continued professional development. So continual learning obviously is good for patient safety. It improves job satisfaction. It allows diversification of careers and skill sets. And so placing a strong emphasis on continuous professional development and giving GPs sufficient time and resources within their contractual obligation to be able to do that is really good for GPs, for their career and for their well-being. And then the final thing is around leadership development programs. So I think investing in leadership programs just to help equip GPs with those skills and knowledge to lead and manage their teams and change effectively is crucial for driving innovation and improving efficiency within the NHS. And I think we neglect that at our peril, because every GP in whatever environment is going to be leading a team. And now I just want to focus a little bit on digital transformation and technology adoption, because clearly that's the really big shift that we are focusing right now. So the plan aims, as I've said, for a shift on digital, and it aims to free up GP capacity by tackling the burden of bureaucracy, which, as they say, steals joy from work and time from patient care, by cutting down on some central targets, delivering some recommendations about, reducing red tape and identifying and cutting needless bureaucracy. And the plan also proposes to roll out technology to cut unnecessary administrative and clinical and clerical work. So the use of ambient voice technology, AI scribes, digital triage, a single patient record, all targeting at ending the need for clinical note taking, letter drafting, manual data entry. And there are some estimates about how much time that might save, and that could be really significant when you put that over a whole population of general practice. In parallel, the plan proposes building AI-powered online advice into our national NHS app, which is used by over 30 million people in the UK right now, ordering prescriptions, booking appointments, and so on. And we're also embedding digital telephony to ensure that all phones are answered quickly. And then just finally, a little bit about the future care workforce. So we are already seeing a real need to go to multidisciplinary teams. As I've said, the use of technology, but remote and virtual care, telemedicine, remote medicine is going to play an increasingly significant role within our environment. And then this, as I've said, we might see the emergence of more specialized roles within primary care, focusing on specific populations. And then this is my last sentence is really about data-driven decision making. And for the future, we will see, through the availability of patient data, an increased ability to make better decisions for our local population, improving efficiency and effectiveness, and maybe creating new roles. And I'll stop there. Maybe we'll have some questions.
Yeah, thank you, Karen. I loved what you shared around retention being a cost-effective way to safeguard a healthcare system. And I think of, as in my time as OMA president, so many examples of what you could think of as gravity, what an amazing doctor in the North called gravity, Dr. Sarah Newbury. Has anyone heard of this term before? Gravity and retention. So gravity are those doctors that have been in practice for doctors or other health professionals that have been in practice for 10, 15, 20 years that pull in other health professionals, other family doctors, other clinicians into a community and keep them there. Right? And keeping those doctors, that source of gravity is so important towards preserving those healthcare systems locally. And I loved how you said that it's cost effective, right? Because you lose money when you lose clinicians in a community. It hurts the healthcare system if you don't retain well. So I'm going to open it up to our first few comments, reflections from the room or from online. We have some runners with mics. By the way, we trained our Deloitte runners as well as the ball crew at the US Open and at Wimbledon. That's what I hear is the level we expect here. So raise your hand if you have any reflections, comments, questions for our panelists so far. Yeah, Dr. Liz Mudd.
Hi, thanks so much for those comments. I mean, I think we look a lot to the NHS as a country the UK is a country that's had a lot of investment in primary care and in trying to understand like the right size for governance, for health homes, for neighborhoods. So we watch what you're doing closely. Can you speak about the 50K number that you talked about, which I've sort of heard before about like how do you right size some of the primary care team or the neighborhood team or the health home, and where do you get to 50K? Like thinking about kind of scaling up primary care teams.
Yeah, no, it's a great question. Thank you. And there is a little bit of concerted thinking behind that. In fact, when I was working in the national team, I was responsible for thinking through primary care networks, which were kind of the precursor of these neighborhood teams, and why we picked initially we picked 30 to 50,000. I think now we're reaching kind of 50,000 scale. We reached that because we started to think about what was the scale of services that you would put into a neighborhood or a local area, which made it small enough that it was that you knew your physicians and your teams, and yet big enough to be resilient. And there is something around a kind of 150 people who work in a network of that kind of size, which means that you can pick up the phone because you know who they are. They're not so far away from you that you don't know who they are. but you can see the size of the teams and the construct of the team. So you've got that personal element, and it balances personal element, with size, which you get some economies of scale essentially. And you could look at how you use the data or how you can amalgamate teams. So you could take a proactive and a reactive visiting approach, maybe to frail elderly, or you could pick any number of areas. But really it came from there. It was that thinking of how do you make this local enough to be a community, and then so that you get that kind of effect. But the other thing is that then you start to pull on community and voluntary care resources as well. So important in those local neighborhoods are voluntary schemes, are social care schemes, are people who work in that local area that are also really invested in those local community assets as well. So I think it brings together the kind of medical, the psychosocial world, but it makes it possible that you can actually know who to pick up the phone to. So that's really where that kind of 50,000 came to. But then moving on beyond that is there are things that you need to do at a bigger scale. So if you're thinking about, I don't know, urgent care centres or diagnostic centres or long-term condition centres, that actually you do need, it's too small to do that at that 50,000. It should be beyond that. So that's where the 50,000 came from. And if you want, I can show you where that primary care network thinking came from.
And Karen, you can't tell this, but people are on the edge of their seat listening to you talk about the NHS and the reform there. I think we maybe have a separate keynote and day just for Dr. Kirkham to share and others to share the NHS innovation. Let's go, Dr. Jayappat, around, I heard neighborhood health service when Karen was sharing, and your lens on health equity. And I never thought I'd be asking this question, what can Canada learn from the US when it comes to health equity? And I bet there is quite a bit, despite our Canadian jokes around this topic. Over to you.
Thank you, and always appreciate hearing my colleague, Dr. Kirkham, talk about the work going on at NHS, which we've been able to collaborate on, and that's the beauty of this conversation is the ability to exchange perspectives and learnings from around the world to help us all be better, right? And so that is really exciting. Let me start with some analysis we did, and currently Americans live nearly 78 years in terms of life expectancy, but spend their final 12 years in poor health. And our analysis that we did recently showed that Americans are living just 65.9 years, 85% of their lifespan in good health, but with improvements, they could live up to 95% of the years in good health. And we're seeing some of that. And partly why and how we're seeing that is when care delivery is organized around geography, neighborhood, or community, not just institutions, and meeting people where they work, live, play, learn, they are able to engage in health in a way that allows them to move towards wellness and health, right? That the point that we were talking about, moving sick care to health, and being able to intervene upstream. And then you integrate primary care, social services, and community resources to address health needs and inequities. And that also is an emphasis of trust between the various stakeholders, accessibility, and population health outcomes over volume of services. So when we think about the ingredients of the recipe that works well to address inequities, it's designing a care model that gets to better health and towards holistic health, and you align the financial structure to pay for primary care teams to care for people, not necessarily only the predominant of delivering services, and ensure that the right quality primary care is available to every individual and family in every community. And you train primary care teams where people live and work. Design information technology that serves the patient, family, interprofessional care team, and quality. And one of the ways that inequities have been addressed is through addressing the drivers of health. So you screen, you refer, and then you close the loop in terms of things like food and access to healthy, affordable food, or transportation to get to and from appointments, or housing. So unstable housing reduces life expectancy by 27 years on average. So when you just and we've seen that in various structures, both at the institutional level, in community clinics, and in primary care networks, that when some of these drivers of health are addressed, they lead to better outcomes and value-based payment structures that reward improvements in quality cost. So it's here, if your patient or family needs particular things, we'll help them get it and we'll work with collaborators to do it. So these are multidisciplinary care teams plus community-based networks of organizations that work to address the drivers of health, provide trusted information, and help patients and their families navigate. And then have consumers really engage more upstream around prevention and wellness. So we can identify things early and act on them through targeted data. And so some of the examples certainly are we're seeing in retail clinics, virtual care, home settings. They're growing rapidly, increasingly willing, and we're seeing consumers increasingly willing to use them for preventive and mental health needs. So in research we've done, 55% said they would like to use retail clinics for preventive care, 47% for mental health. 66% said that they would use virtual visits for preventive care. So the three anchoring elements, I would say, are investing in place-based primary care, so community health centers, and collaborating across an ecosystem. So instead of the fragmentation we have, saying what are the roles that different organizations need to play and how do we construct and then pay for models that support that. So team-based and integrated models of care, whether it's integrated behavioral health and primary care through warm handoffs, the digital work that Dr. Kirkham was talking about earlier, and then AI-driven capabilities to help people make the healthy choice the easier choice, and help them understand their own health better, which consumers are challenging the system for. And embed equity in funding and measurement. So tying investments to outcomes like access, chronic disease control, avoidable hospitalizations. And I'm a geriatrician, so I also think a lot about older adults. And one of the most promising areas has been through our PACE program for all-inclusive care for the elderly, which is all-inclusive medical, behavioral, and social health services. They're coordinated through interdisciplinary teams, including physicians, nurses, therapists, social workers, and aides, where you have high-touch personalized preventive care. And it can be done virtually, in brick and mortar, combination, and it helps people age in home and in the community. And what we're seeing is a 12% lower cost compared to traditional options. Fewer than 20% of PACE participants spend extended time in nursing homes prior to end of life, making it more affordable, fewer hospitalizations, a tune of 24% reduction and shorter length of stay, most importantly, better functional status. And you think about the way that we organize is the 4 M's, starting with what matters to you, anchoring in that patient, family, consumer preferences, and then looking at mentation, mobility, and medication management. And what the data shows, and when you deliver those 4 in a bundle together, however you do those 4, for your organization, your community, leads to better outcomes at lower cost. And then we see certainly a lot of the efforts around primary care and accountable care organization models that are data-driven model features where you have systematic collection of data on demographic and drivers of health, stratification and regular reporting that lets you act on it. Because also that risk is not static. Risk is dynamic. It changes week to week, month to month for people based on what's happening in their lives and their community. And building local partnerships with community-based organizations for referrals and integrating social services supported by ongoing data sharing and workflow integration. And it's also understanding what people are doing at home, right? If they're in the 4 walls of a clinic, you may not also necessarily know what's going on at home. There's a patient I took care of who was new to me, who I visited at home, and her refrigerator didn't work. She didn't have a ramp to help her get out of the house. She was isolated. She was a diabetic. So you think about insulin, food needs. She also didn't have the right environment to support her respiratory status. So her COPD would flare up. So there's, but you got to see that. And you got to have the data to help you act on that and then have who are the collaborators to help drive that. And then I would say access, workforce training, digital health infrastructure, and continuing to say that primary care is a platform for healthy longevity. When we talk about a lot of this conversation that's happening now around longevity, and it's about more years in good life. And I think primary care is really the platform for that.
Primary care as the platform for health and longevity. I saw a lot of hearts from the online audience when you talked about place-based care, especially for older adults. I can't help but wonder, Jay, we've had this whole conversation around social prescribing globally and in Canada, maybe link workers as part of health teams and community health centers, family practices. In the NHS, there's a commitment to connect every single family practice to a link worker so that clinicians, family doctors feel supported in navigating the social determinants. How are you seeing that play out internationally and in the States, the link worker social prescribing conversation?
I think it's a continually growing conversation. I would say that community health workers, promotores, patient navigators, they have a number of different ways that we talk about them or functions. Globally, have actually been such an important part of the primary care story. And in the US, now we're getting around to it over the last 5 years, where we're seeing through various efforts the growth of community health workers embedded within care teams, within workforce settings, and being paid for and reimbursed through various mechanisms. But that's part of it. And then you think about what's a high-performing community-based organization network, right? In a community, there might be 4 different organizations that support the same community-based services or social services. The work to integrate them and create the highest performing organization to deliver those services has been an important part of that story too. And I think when you incentivize health and then create the payment structure and the support structure around what needs are to be healthy, you see the improvement in outcomes and lower cost. And social service prescribing or social prescribing and community health workers, again, are such an important part of that story, and happy to share more about that work.
Yeah, thank you, Jay. Next question goes to Dr. Alex Dobranowski. Alex, you lead in digital health and AI. We also have a question from Alberta that doctors, primary care professionals, there are different expectations for how they work with technology. There's a need for supports for the clinicians doing the work behind the scenes. What's your lens on the biggest difference that AI is making practically on the ground now for health professionals, and then what it could be doing in the next few years?
Sure.
Big question.
Yeah, no, great question. Thank you. And, I think there's already been some really, both important and illuminating, perspectives that have been shared. I'll get back to your question in a moment, but so the company I run, we started here in Toronto. Over the last few years, we've had a chance to grow and scale. We work in 11 countries, and we're really focused on solving the problem that I think was already voiced a little bit about around data interoperability. So that's number one. So breaking down silos in healthcare data. And number two, being able to use that data from a preventative care perspective. And what we've developed, our competency around AI, is first and foremost just taking silo data and improving its quality. And the second is then being able to screen that data from a patient risk stratification perspective. And just to give you an idea of some of the scale we work at, we're now, I guess through our entire ecosystem, there's about 150 million lives that our software or AI capabilities touch globally. So we're a good example of AI in production at some semblance of scale. Now to answer your question, actually, I want to make one more quick comment, because we also do a lot of productive work in the NHS, both in England, Ireland, and Scotland, the Middle East, other countries in Europe. And a lot of the feedback that we get, for me as a clinician, is actually become a little bit, even some would say, alarming. So we've gone from listening to administrators, health authorities talking about these significant problems to now them actually describing them like the NHS probably is one of the only organizations that's had the gumption, right, to use the terminology, let's say, so transparently. But we're hearing a lot of words like, this is catastrophic now. And I don't know yet how to make sense of that. But, now there's a growing group that thinks, okay, well, maybe one of the only solutions is leaning on some of these predictive technologies, AI models, et cetera, to really accelerate innovation. I thought I'd just add that because it is pretty professionally frightening to hear this from so many different jurisdictions and health authorities. Now, sorry, back to your question. So
How do we make it joyful for the health professionals? How do we support them in doing the care and turn this, what you'd call catastrophe, or what the NHS is calling existential brink, around with technology?
I think change management, everyone here, are experts, far beyond, my limited experience, but change management, technology adoption is difficult, especially I'd say in healthcare. But I think there is a level of optimism I want to introduce where, innovation in healthcare, that time horizon used to span decades. Now it's been compressed right to months, et cetera. And we're seeing health authorities, start to scramble, and physicians as well, from an adoption perspective. I think in primary care, what we've seen from our lens in Canada is effectively two buckets where AI has started to hit some semblance of scale. The first is AI tools that are assisting efficiency and physician and clinical staff workflow. These are tools that we are probably all familiar with already in terms of ambient scribe technologies, tools that help administrators work with basically digital traffic and inboxes, et cetera. These are starting to now hit a more, let's say, pervasive scaling within some, healthcare jurisdictions. Where we play is more on the clinical side, and from a risk stratification perspective. And I'll say, though, that the scalability right now, although we've started to grow as a company, if you look at all patient interactions, right, it's extremely nascent still. And we're noticing that there's multiple different camps, okay, from an attitude perspective with regards to adoption. There's certainly an old guard in healthcare, which is fairly resistant and even in some instances combatant to change. Anything that threatens their workflow, threatens their way, for instance, to produce an income, right, is automatically kind of put into a category of their attitude being kind of very defensive, versus a change in a younger generation. I'm in my early 40s, and I'd say that, I don't have a single colleague that isn't either learning about predictive technologies and how to apply them into their practice, or is already using them. So there's two, now to answer your question, there's two kind of very different ways that we work with either clinical support staff or physicians, dependent on kind of which camp they land in. But I'll stop there. So,
Thank you, Alex.
Thank you.
Yeah. Any questions from the reflections from the room? I see one over here. Let's get our US Open runners to. Why don't we go with Beth first, and then we'll group a few questions together. So Beth first, and then Elaine over there.
Sure, thanks. I'm Beth Perry. I'm a family doctor. So my question comes actually leapfrogging off of this a little bit, and I practice in the context between urban and rural. I'm in a smaller city. And so I think when we're thinking about some of the system change and some of the challenges we are experiencing in Ontario, is that we do have quite a varied and unequal structural element across our province. And this really results in a lack of enablers that we're experiencing, especially as clinicians. And so how have some of these enablers been built? And as you're saying, that we have some clinicians who are ready to adopt things and others, in the space where we need to meet people on the change curve to bring them forward. So how have some of these other spaces been able to build in enablers as well as develop engagement? Because we do experience low engagement with a lot of our colleagues across the healthcare landscape. And how do we implement that change management in a meaningful way to actually work towards the scale and implementation?
Thank you, Beth. Let's also go to Elaine for a follow-up.
Thank you so much for sharing. I have a two-part. I think the piece about change management and using data for decision-making and incorporating that predictability of technology. So my first question is around what do you see are the intersection between data-driven decision-making and the intersection of patient as custodians to their own health information? That's one. And what are your thoughts in terms of AI tools and accessibilities, and how do we overcome the barriers to access as they relate to social determinants of health?
Thank you, Elaine. Could I go with Dr. Mirja Sjöblom around the financial incentives and motivators piece? I think that's part of, Beth, your question around change and getting a workforce to change and adopt. And then we'll go into barriers. And I do want to go to Karen around the AI tool and Alex around the AI and clinical pathways, which goes to Elaine's question. So let's go with Mirja first around incentives and what kind of financing helps for these types of conversations.
Yeah, no, so I will talk a bit about the Swedish system and how it's governed and financed, and what kind of engines of innovation that has created for us. So what I would say that typically people they might know that Sweden is similar to Canada, provide universal coverage and high quality primary care, but what many people don't know is that it's actually a very marketized system, and 46% of the primary healthcare providers in Sweden are private. So the system is governed by 21 regions that plan and fund and also contract the providers, both public and private. And the public and private compete for public resources, basically. But there is a level playing field, so they compete with each other. So in terms of how the providers are paid, they mainly is through risk-adjusted capitation. So privates get more funding for patients who are older, sicker, or living in disadvantaged areas, and less for those that are younger and healthier and less expensive to treat, right? So this leads to an uplift for rural and underserved areas. There are also some fee-for-service and performance-based payment that play a role, but the trend in recent years has been to shift away from those types of mechanisms, because continuity of care has been a big challenge in Sweden, and the risk-adjusted capitation works much better if you want continuity of care. So I wanted to give a little bit of background about how this private provision came about, which was not always the case. But in 2010, so it's about 15 years ago, Sweden introduced something that was called the patient choice reform, which gave the patient right to choose whatever provider that was accredited in the system. And in the early years, this improved access overall, but disproportionately for the younger and healthier and the wealthier patients. So this raised a lot of equity concerns, and this is why there were an introduction of more incentives to provide services in rural areas that I already spoke about. But I would say that in my own research, I've seen that the private providers, they tend to cluster in the centers and where the wealthier patients are and healthier patients. And the public clinics, they still remain sort of the providers of last resort. So now I wanted to speak a little bit also about innovation, and that's what we talked about. So I think what an unexpected sort of feature in the system. I think when they introduced the system, they thought, okay, there will be a lot of diversity in providers and maybe some clinics just catering to diabetes patients or younger populations, etc. But what really was the big shift was when the digital private providers entered the market, and this was about 5 years after the reforms. And now we have a lot of companies like Kry and My Doctor, and they have really pioneered telemedicine. They do digital triage, and they also offer digi-physical care. And this is sort of how the system is evolving, is that many of the digital providers, they were first only digital, but now they're triaging patients through the digital care, and then they have physical centers that they send the patients to. And they're also early adopters of AI, using AI-driven decision support. And I would say that they've also, through partnerships with the government and academia, they have positioned Sweden as global leaders in digital health. But more importantly, these private sector innovators, they have also, and I think this responds a bit to the question, like how do you drive innovation and these change processes? What you see is that the public sector has also become more innovative because of the competition from these private providers. And there are lots of new models. And one of them that I thought I wanted to raise is because I think it's quite relevant for Canada. It's one that it's in southern Lapland, so it's the very far north in Sweden, where you have, I think, similar challenges to Canada. The population density is very low, less than 1 person per kilometers. And the staffing is a really challenging problem. And in this, the answer to these challenges in this model is something that they call the cottage hospital model. So they basically have a small local unit that's staffed with GPs and nurses, but they cover a vast scope of services, from urgent care, maternity care, minor surgeries. They have X-ray, ultrasound, basic labs. So it's more than what the normal primary healthcare clinics will have. And then they are linked up to specialists via telemedicine. And in this setting, they have also created this virtual health room so that residents can self-measure and connect by video instead of traveling, many hours. And they run more than 40 telemedicine applications daily in this network. And it's also been sort of recognized by WHO as best practice model. So I mentioned the private sector as an engine of innovation, but also adoption in the public sector. And the last sort of silent engine of innovation in Sweden, I would say, is the partnership between academia and clinics. So for instance, in Stockholm, we have an academic primary healthcare research center that supports about 600 units, both public and private, with research, continuous education, and quality improvement. And we also have these university primary healthcare centers that combine training and research, and it functions as a learning lab. And I think this also really helps with adoption of new technologies. So I think I'll stop there, but I just wanted to highlight what's happening in Sweden, and I'm very happy to get some questions also if there's any specific areas you want more information about. Thank you, and over.
Thank you, Miriam. Someone did ask about an example for how to take into consideration rural and northern context. I think you gave exactly that in the hospital team model connected to primary care and specialists. We have some questions around the AI digital front door in the NHS. Maybe I'll go to Karen first for that, and then Alex, if you'd like to comment. Sure. Is that working? Should we be doing something like an AI digital front door for primary care in Canada?
Yeah, so it's been interesting because we have just started this journey in the NHS around trying to put everything through this kind of front door that patients can then be triaged more effectively to the right care provider. So for instance, someone with back pain doesn't automatically need to come to me as a GP. They could go to their first contact practitioner in physiotherapy, et cetera, or someone with a request for a nursing appointment can do that too. So there is something that is, really accelerating in the UK around this. Where do all the cases come in? Then how are they digitally triaged? And then how does that then accelerate you through to the right provider, right time, right person, within obviously the right time scale? And there is something in that around making sure that you identify those very clearly with urgent care needs so that they are screened out straight away and they go straight to someone to be able to answer the phone, or this is not appropriate for this kind of service. Equally well, you can start to signpost people to non-medical care settings. So, in the UK, our pharmacists are really well equipped to deal with many minor ailments. And why would you wait to see a GP when actually you can go to see your pharmacist for many minor ailments? So that element is working really well. I just want to pick up on a couple of other things around kind of AI, because that is just one element, the digital front door. I see huge opportunity. I think already we've kind of touched on it for around administrative tasks. So, taking all of those, the automation of appointment scheduling, etc., other, really mundane clinical tasks. And I think agentic AI, just been thinking a lot about, not just kind of the AI that we use now, but the AI that we'll use in the future, and the opportunities for that could be rapidly scaled. There's the clinical decision support, which I remember hearing something that Atul Gawande said a long time ago. And he said, you clinicians can't remember it all in your head. You're going to need to go and look for where you can get the resources quickly to help you make some decisions. And we are certainly at that inflection point now, if we hadn't got to it a few years ago. So there is something around that. And then the other area around AI that I think is really important is that data analysis and reporting. And I think we have, certainly in the UK, because we've been fully digitalized in primary care for 20 plus years. I think I put my first digital system in, a patient record 22 or 5 years ago or something like that. We have this enormous potential for a long-term care record that allows us to be able to pull the insights. And in the UK, and I'm sure around the world, it's really hard to combine data sets between acute and community and primary care. But that is the gold dust. That is our stethoscope. That's our new way of being able to understand what's happening in our population. How do we analyze those trends and patterns? How does that inform our healthcare planning and resource allocation? And how does that allow us to spot deterioration earlier? So those are just some of the ways that I think that we could start using some of these really important technologies at our fingertips. And just quickly to say that I think change management is going to be really important here. It's really hard to get very conservative clinicians to adopt new ways of working without really fantastic evidence around it. And others will be, well versed in this already. So we have to really be really clear about the evidence, about the safety, about the regulations as we put in these new technologies, so that people feel really confident in using them.
I see Jay off mute. Let's get a brief comment from Jay, then go briefly to Alex, and then get some more reflections from the room. And then we're near the finish line for the session. Jay, over to you.
Thank you. I was just going to flag, to add on to the comments made about change management, is we've just released a paper that talks about principles of change management for clinicians, particularly in the context of technology. So clinician-led, collaborated with from the beginning. There's demonstrated value. It's clear through story and understanding to patient and clinician workflow, trust in the data. Clinicians will act on data if they trust its source accuracy and relevance, incremental and visible wins and celebrating that, and a culture of learning, not compliance, right? And data-driven care is continuous improvement. And then I would say the other example to earlier question about AI, and you reference ambient technology, ambient tools, revenue cycle, documentation burden, those are places where ROI on generative AI is clear. And Agentic has other places, even if you can just help scheduling. For a $2 billion system, if you can help people spend, 75% of their time within the system, it's a $40 million revenue impact. So this piece about trust, loyalty, keeping people connected in the system. And then I'll give one last example that I can talk about more, is the North Carolina Healthy Opportunities Pilot addresses some of the rural health questions that you raised, and is a terrific pilot to learn from in terms of what Canada could personally do in terms of addressing health holistically.
Well shared, Jay. I do take back my comment about Canada not having as much to learn from the States. It sounds like we do have a lot to learn from many of these examples that you're sharing. Alex, would you like to comment briefly?
Well, I think I'll just add that the system, as we are all really aware, right, our healthcare systems are so constrained that we're going to have to turn to some of these tools. But, echoing a little bit, it has to be done in the right way. Evidence has to be produced, et cetera, right? You got to work within all the kind of authorities, including, patient privacy protection, et cetera. But I think now we're witnessing also regulations start to accelerate. So as that begins, I think adoption then will accelerate behind it, and we'll be able to make some headway.
Yeah, well said. I'll hand it over to the room. Some closing thoughts, reflections. Who would like to share? Let's go to O'Neill.
Hi there. Is this working? Yeah. I'm O'Neill Bhattacharya. I'm a family physician, clinician, scientist at the University of Toronto. It's a question for Dr. Karen Kirkham. So I'm really excited about the potential of digital front doors. Health systems are complicated and hard to navigate. But I'm interested if we, filter the patient to the right thing. What about the patient with 5 problems? And is it going to be the most efficient thing to send them to 5 different people? Or, the generalism, like what do we do with the generalism of family doctors, which should be a strength on some level?
Yeah. Should I answer that now, Dominic?
Yeah, go ahead, Karen.
Okay, yeah. I think it's a great question. And I think the art of some of this is to knowing where your patients are and where you're going to meet them. So I absolutely agree with you that you could spend a whole lot of time on a patient who's got like five different questions, those complex patients. I think we need to be risk stratifying our patients. So it's if you know your patients and your list really well, which comes back to you need to keep that really personal identity, you'll be able to say, actually, this patient probably shouldn't be triaged 10 times to a pharmacist, a nurse, a physio, etc. This is a patient who has complex needs, and we know they are, and we know that we need to triage them differently, and they'll probably be flagged in a different way. So I think we just need to work with the system so that it works for us and not against us. But it's a great question and something that we just need to work through. And in some of the practices in the UK, we flagged people got very intermittent needs, very much long-term needs or complex care. And there's a different route for those patients. So that's all in development, I think. But it's a great question.
Thank you, Karen. We have a question from the reflection from the middle of the room here. Go ahead.
Hi, my name is Eric Sandy. I work for an organization called Medavie. We're a social enterprise. We work in emergency, community, and primary care. I'm interested in the debate in Europe around private care. So we just heard in Sweden now 46% of the physicians deliver private care. It's been the third rail in the conversation in Canada for ages. In 2010, you could be hard-pressed to find a Canadian that would advocate for private primary care. Most recent research from Angus Reid says about 40% of Canadians say there's no room in the Canadian system for private care. 30% want it today, and the other 30% are what you'd call private curious. They're interested. And I think this has all been driven, of course, by access issues, wait times, et cetera. And if you look at the province of Quebec, 5% of the physicians there have opted out of Medicare now. That's almost 1,000 doctors with 600,000 patients that are willing to pay $250 every time they see a physician. So I think there's a big cultural debate that's happening here, and it's only going to accelerate. Now, to be clear, I work for a social enterprise or a nonprofit. We don't have any private care or plans for that. But I'm interested in the debate in Europe around that. Has it, in fact, been a debate? Was this seen to be an erosion of the public system? Or how has that actually transpired?
Yeah, thank you, Eric. This sounds like a perfect time for Amelia to offer up a reflection around what's the role of private and strong healthcare systems.
Yeah, so I think it's a very much an ongoing debate in many countries. The latest debate that I'm quite interested in is it's not only about public versus private, but it's more, what kind of private providers do you want in the market? What type of ownership structures? And in my research in Sweden, I actually saw that the owners also influence how the physicians and the healthcare workers behave. And if you have private equity owner, they're going to drive them towards more profit maximizing strategies, etc. And I think one of the sort of challenges that you have, especially now that you see in Sweden at least, is when you have very fast-moving technological companies driving the digital innovation, is for the the regulators of the markets to keep up with them. And we have had examples of, their loopholes in the regulations and that they take advantage of. So I think what I would say is if you go for private, which public or private, I don't think the discussion should be about public or private. It should more be what kind of systems do you want and how do you incentivize whatever providers you have to deliver the public objectives in that system. And the experience from Sweden shows that you need to have incentives for the providers to go to the most vulnerable, to the rural areas in order for it to work. You also need to look at the owners, what type of owners, how much profit maximizing strategies do you want to have in your system? And I would say, lastly, the discussion about, there's often a discussion, it doesn't matter what providers you have as long as they deliver results. But what we have seen in Sweden is that it's not always very easy to measure those results. So the governors of the market needs to be able to have clear indicators for measure results across both public and private providers. But it is an ongoing debate, and yes, I'm looking forward to see what path the Canadian system will take.
Thank you, Mirja. So as we draw to a close, we'll ask all of our panelists to share in one or two sentences, your words of inspiration for a stronger Canadian healthcare system for everyone here in the audience today. One or two sentences at most. Jay, can we go to you first? What's your words of inspiration, words of wisdom for all of us in the room or online here?
Well, thank you so much for the opportunity. There's a need for a health system that's a community-oriented system, which provides clinical care, but is being led by public health to create the programs, the partnerships, the actions, and the system transformations, at a city, state, and provincial and national level. And I think that Canada, with the resources, the talent, the infrastructure already there, and the ambition, can certainly get there and be, a light of hope and opportunity for its people and for all of us. So thank you.
A light of hope and opportunity for its people, all of us. Beautifully said, Jay. Alex, let's go to you next. One or two sentences, your words of inspiration for all of us here in the room.
Sure. I have my experience now is more, on the enterprise side, the private side, and you see all sorts of incredible entrepreneurs, building different, key pieces of technology that is improving patient lives. But really, where rubber hits the road, it's in the public sector. It's, innovative leaders that are working in health authorities, hospital systems. That's where you get the material impact on patient outcomes at scale. And I think, in Canada in particular, we do a pretty good job of attracting very talented people. And I think, on one hand, we need to be retaining physicians to give that, direct, patient to physician care delivery, but we have to also be retaining, those innovators in healthcare that are in the public sector, right, so that they can continue to do their work and be supported. I don't know if that's much wisdom, but that's a perspective. So
well said,
thanks.
Alex. Karen, over to you. One or two sentences, your words of inspiration for us.
Okay, thank you. So the first thing I would say is learn from others. I think we've all made plenty of mistakes. Don't make the same mistakes. There's plenty of real world stories out there. That'll be the first thing. The second is, in all the work that I've done, when we've gone from a clinically led scenario and the clinicians working alongside the managers to try and implement something and some change, that's worked. And it's because clinicians stay and work and live within those communities. That's a real recipe for success. So put your clinicians at the heart of your care delivery change.
Thank you, Karen. Here. Mirja, over to you. One or two sentences, your words of inspiration.
Yes, so I think the cornerstone of any healthcare system is the people that deliver care. So I would say first, take care of your people, however you want to do that. The second thing, we talked about private sector and market, and there I would say design the market. Do it consciously. It's very important. And finally, curiosity. Both when it comes to policy design and also adopt new technologies. Everything is moving so fast now. Let's all be curious and learn. Thank you so much for the opportunity, and over.
So We went through a hurricane of a global panel today, starting with innovation, AI, workforce development, training, neighborhood health services. We talked about social prescribing. We spoke about what does hope look like for our healthcare system? How do you scale that? How do you build in private sector contribution to a strong Canadian healthcare system? And so much more. I want to give a big round of applause for our panelists here today. From all over the world, thank you for joining us, and all over Canada, those of you online. I see lots of hearts and claps coming in for all of you panelists online, and for you, Alex, as well. And I'll hand it back to Tom to close.
Yeah, terrific, Dominic, and great chairmanship. So round of applause for Dominic. Folks, great job. We're going to take a 15-minute break. Folks online as well, 15-minute break. We're going to get back for our national panelists. And let's start sharply at 11:30. 11:30 in the room. Thank you.
Hey, great job. Thank you. Thank you for that. Yeah.
Okay, folks, we're going to get started. Welcome back. And for those online, welcome back. I am so pleased to introduce Dr. Liz Mugga, who is from Ottawa. And we got our whole panel in place here and from across the country. So Liz is going to introduce them. Liz is associate professor at the University of Ottawa, my alma mater, in the Department of Family Medicine. She served as president for the Ontario College of Physicians in 2020 to 2022. And she now is the provincial clinical lead for primary and community-based care at Ontario Health. Lots of good stuff, and they are jumping on the opportunity for primary care. So Liz, we look forward to your leadership in that. I don't want to speculate whether you have a dog or not, but I guarantee it would be a very friendly, enthusiastic, with lots of the dogs in the park following. All right. So really great to have you. The folks online have no clue what I'm talking about, but that's okay. It'll be our little joke. Over to you, Liz, to introduce your group.
Perfect. I think I'm mic'd up. Can everyone hear me? Perfect. So just thank you, Tom. Thank you to Deloitte. Hello to everyone who's joining us online, and obviously the group here in person. This is a tremendously important time in Canada. Our attention has turned to primary care. All of us in this room and folks online would know this has been something we've cared about and has known to be, we knew this to be foundational to high-performing systems in Canada, but to really see it at the front line is exciting. So the conversation today that we're going to have is going to be practical. I want to, really emphasize the leadership that we have, and we'll have each of these amazing panelists speak to their experience and the work that they're doing. But we're hoping you come away with some practical ideas about what next, what's worked, what hasn't worked across the country. And I wanted to just say as well, I want to pull Monique Bégin into the room. So she was the, as you know, health minister, author of the Canada Health Act. And one of the things she talked about was the most important guardian of the health system in Canada, is the patient. And the patient is not here. I mean, we are all patients, but we don't have the patient voice. If we don't have the patient voice, foremost in our mind as we talk about primary care, I think we will be led astray. So let us welcome them into the room, the patient and community, as we talk about primary care. So we're going to start with some introductions, and I'm going to ask each of the panelists to just say their name and their title, the organization they work for, and then in a sentence, to start the conversation, what do you see as the biggest opportunity in primary care in Canada right now? So Chris, we'll start with you.
Great. Hi, everyone. My name's Chris Solway. I'm the Chief of Strategy and Partnerships at an organization called Ontario MD here in Ontario. And we are an organization, a delivery partner with the government, with Ontario Health, supporting conformance and compliance of digital tools, building some tools, and we have a field team across the province that supports physicians, nurse practitioners, primary care clinicians as a whole, with the change management of the deployment and adoption of those tools. We're also a subsidiary of the Ontario Medical Association. So we also there on that role are working with clinicians around digital practice optimization. And in the context of primary care, specifically with the section of the OMA that focuses on family and general practitioners, SGFP, in supporting them with their digital needs. And you can tell from my intro, my bias is around some of the greatest capacity, I think, is in digital, as we need to have conversations around supporting some of the critical things that we're seeing almost in crisis within primary care. So whether that's creating capacity, whether that's enabling really integrated team-based care, whether it's providing the right data, patient engagement, bringing that joy of medicine back. I think a lot of that can be supported with really well-developed digital tools and strong data.
Thanks, Chris. Vanessa, over to you.
Thanks, Liz. It's a real pleasure to be here. My name is Vanessa Wright. I'm a nurse practitioner at Women's College Hospital. I am also a postdoc fellow and assistant professor at University of Toronto in nursing. What is the biggest opportunity is really bringing people in, thinking about opportunity for health and social care collaboration. Those who are often working in social care sectors are members of communities. This really allows us to think about capabilities and motivations and opportunities for change. And that allows us to build really from the outside in. So deconstruct and reconstruct.
Excellent. Like that. Thanks, Vanessa. And Dr. Brad Baller. Brad, over to you.
So I'm Brad Baylor. I'm a family physician in Sylvan Lake, Alberta, actually. I'm also the medical director for a group called Health Innovation Group, and we support practices, practice change, system optimization, rollout of new funding models in many of the provinces in Alberta right now. And historically, I was also the provincial medical director for primary care networks in Alberta, and I led the largest change management team oriented towards physicians in the country for a decade. In my sentence, I think there's two things I would like to say. One, there's an opportunity to leverage communities and community activation to develop systems of wellness in our spaces in Canada. And second, we have to look after the people that work in the system. And I know a lot of us say that, but practically what that means is developing places for our clinicians to work where they actually like to work and want to keep working in them. And that's harder, easier said than done sometimes.
Hmm. Thanks, Brad. And last but certainly not least, Dr. Nadia Veilleux, to you.
Hi, so my name is Nadia Veilleux. I'm also a family physician, and I'm the medical director at New Brunswick HealthLink. And for those of you that don't know what that is, HealthLink is the program in New Brunswick that was tasked with managing not only the registry of unattached or orphan patients, as we call them, but also allowing them to receive primary care while not having a designated primary care provider while they are on this unattached registry and waiting for attachment in a local primary care group or health team. And I love what everyone has just said about those opportunities and building communities and bringing people in. And I would say that I think the biggest opportunity in primary care nationally and provincially is building connectedness. We know that primary care is publicly funded, but probably 70% privately delivered by family physicians' offices or physio offices. And so how do we build connectedness in this very siloed private environment is, I think, our biggest opportunity to build networks and build a system.
Excellent. Thank you. Okay, so we're going to start with, we've got a couple of themes. I'm going to ask each of the panelists to answer on those themes, and then there'll be lots of opportunity to get your questions as well as questions from those online. So please get your questions ready. You're welcome to be provocative, and I'm happy to be able to pass on the provocative questions to our four panelists. Chris, we're going to start with you around digital, of course, and I want you to get really practical with us and talk about what are those concrete practical approaches that have happened in Ontario to really transform primary care that have made a difference in terms of the administrative burden, care coordination, et cetera. So tell us about what's happened, and you're welcome to muse a bit on where there've been successes and where you've noted challenges as well.
Yeah, thanks, Liz. So I've got three areas I'm going to focus in on. And as you said, each of them, we have the beginnings of successes that I can point to into Ontario. I think the first one is really around driving innovation. I think we've already seen beginnings of where new technology can come to address things that are problems within primary care, whether that's easing administrative burden or supporting clinical decision making. We've just recently done a large provincial evaluation of looking at something like an AI scribe that, when you're bringing it into primary care, can save up to a half day of administrative time. And we're now starting to look at it around clinical decision support. And I think that needs some targeted investment and structure, and it needs to be primary care led. I think for this to be really successful and for innovation to continue to drive both improvements, and then what we heard, I think, a little bit this morning was around transformation and how digital can enable some of that transformation that's being led by clinicians. We need primary care clinicians at the heart of it. We need them, we all know the opportunity of AI, and we know that people are saying that the greatest opportunity is within health. For that to work, you can't just say bring in AI. What people in this area would say is that you need to identify the problems and the critical things that you were looking for AI for solutions, and then find that match. And that needs to be led by physicians and clinicians. And there needs to be a strong evaluation program. This is in Ontario. We've started to do some work with the evaluation group with O'Neill at Women's College Hospital. We're really defining from a physician and clinician perspective what is value, what is quality. We're able to dive into some of the legislative and privacy elements that come up with this new innovative technology. And then I think the biggest part that we really need to add on is scaling that. Once we have found something that a new innovation, new technology that can address a key problem, it's scaling that and really getting that into all the practices across the province. The second one, when we talk about innovation, frankly, if you talk to some of the frontline physicians and clinicians out there, the idea of innovation, new technology, they're like, I can barely keep my head above water with what I have. I think, and it can't be a sequential thing because we have need for this to happen now. We have to drive innovation, and I think we have to put some investment and structure around the digital capacity of primary care. You know, Ontario MD came into being about 20 years ago to move physicians from paper-based records into electronic medical records. And then over that 20 years, the complexity of the digital ecosystem has just grown and grown and grown. And all of that has continued to be picked up by physicians and by their clinics. And frankly, it's getting to a point where, as we know, that burden, we did a recent survey of physicians, you know, when they have a IT or EMR problem, up to 60% of the person who has to deal with that is the doctor. So we're taking away from time that they could be with patients to deal with IT or EMR problems. That infrastructure needs to be built up, and we need to be able to support the 7,500 clinics across the problem with that across the province. My career started in hospitals, and there, when you go to a clinical team in the hospital, either to address a problem or to bring in a new technology, there is a whole IT department that comes and supports them, knows their workflows, knows what they do, knows the strategy of their organization, knows how they're going to help them. We need that equivalent of that IT department to be able to come and support the primary care doctors. I think also it taps into also practical parts around economies of scale. Right now, a lot of these, whether it's you're purchasing your IT tools or the licenses, are done individually across the 7,500 clinics, and we are not getting great value for physicians and clinicians. I think if that was done with a more coordinated provincial lens on that, we could also achieve greater value and economies of scale with that. The other part I'll put into that in terms of it's come up a couple of times this morning, is not just about the technology and license to products. It's also around the change management or the practice facilitation that needs to happen of teams of people who really know the workflows, know the purpose, know the daily interactions that happen in the clinic, and they're able to bring those, show how those tools can be optimized and really support that workflow. And I think the last one I'll focus in on is around interoperable data flow. We know, and it was highlighted again this morning, that right now there's a huge opportunity in the data that's collected every day by primary care doctors and clinicians. And right now, a lot of that is locked up in the EMR. The government, many jurisdictions are starting to tap into this. Ontario has set out a path to try to drive better value for this, and we hear from research, the group out of University of Toronto driving what the expectations are patients around being able to access their data. All of that needs to be true and front of mind. The part I'd also add is there needs to be a data strategy, a data lens that also brings value back to the primary care doctors and clinicians. The other parallel to the hospital infrastructure is, if there's a cardiology team who are looking to either do, quality initiative or understand the flow of their patients, they have a decision support department that comes and reflects data back to them. How do you improve operations? How do you improve clinical indicators? We need to have that same infrastructure invested in and provide that back to physicians and clinicians so that they can drive that better improvement at the coalface. And I think there's a great opportunity there to have that strong engagement with patients. That then taps into other opportunities like primary care focused research, population health management, all of the things that we see there. And I would say that the practical nugget here is actually where in one of my previous jobs was able to work with a number of community health centers in Ontario. They, I think, have tapped into this opportunity of really be able to pull in the data that they collect at these community health centers and reflect that back into population health management, understanding how they're doing screening. And it's something that's been, it's been done for a number of years at the community health center. And I think we need to take some of those learnings and really scale them up at a provincial level.
Chris, I'm going to just ask you a follow-up on that, which is because I think these are excellent principles. And I wondered if you could share, when we're talking about things like change management or scalability and overcoming privacy and other risks, what's the example that comes to mind for you, either in Ontario or somewhere else in Canada? You're like, this worked. This innovation, we got it right, and it didn't take us 10 years. And
So I think the work that it's happened in Ontario and supported by the ministry and Ontario Health is around this example of AI Scribe as a new technology. We started this work when there was just 6 vendors that had customers in Canada, and we were able to do with partners do a strong evaluation of what that value proposition was. At the same time, we were able to bring in the key privacy and liability partners within the system. So in Ontario, those are things like our Information and Privacy Commissioner, the CPSO, there's the insurance players for physicians, CMPA. We went to the Minister's Patient Advisory Committee, able to bring in a collection of perspectives to make sure that we understood also what the privacy and liability issues are and come up with effective mitigation. And the way this has moved from just an evaluation and a pilot is now the province has invested, and there's a number of programs, I think, nationally and provincially to really do that spread and scale. And I think probably within a year and a half, 2 years, we're starting to see probably, on that adoption curve, my estimates, I think, in Ontario is we're probably somewhere around a 35% adoption rate of this tool. And I think that's happened because these programs help clear the path for is it safe for me to use, the privacy and liability issues. And there was strong different programs addressing the financial elements of that, and I'd see that's an example of where we're able to move, and it's supported. Ontario MD is part of that program, and we support them with change management, making sure that especially the practices that aren't digitally savvy, they understand what the technology is. There's that extra help to make sure they can adopt it into their workflows, make sure they make the adjustments, and it hits its maximum potential.
Yeah, I think that's an excellent example. And I think it's critical that we learn and do the postmortem very rapidly as something works, so we can do it even faster the next time on some of these innovations. Vanessa, I'm gonna turn to you now, and I want to say how happy I am that we have a nurse practitioner on the panel. One of the things we heard about this morning with the international panel, and I think everybody is talking about across the province, is team-based care. So I am going to ask you about team-based care and what you think team-based care has to offer on a number of fronts on sustainability, like this problem of recruitment and retention, on expansion of our ability to attach and operate more efficiently, on creating workplaces that people want to work in. So I want you to talk about that. And then I know you're also an academic, so I'm interested in what you think about what's the role for our academic institutions around training, around teaching, maybe also around culture change. So you're welcome to, give us your opinion on that as well.
Indeed. Thank you. Thank you so much. So I'll start by engaging with this question from 2 perspectives. I'm a nurse practitioner, or NP, as Liz mentioned, and I'm also a strong proponent of team-based care, really from a research perspective and also the concept of team science. I've been really fortunate to witness who and what and how can be leveraged for effective team-based care. So I'll use that to describe several personal exemplars to demonstrate access to care innovations for underserved populations as well. So NPs are integral members to primary care teams across Canada, and we have over 9,000 NPs in Canada. And in Ontario, we have 5,400. So aren't we lucky in Ontario? In Ontario, there are 79% of NPs practice in primary care. And in Canada, for context, there are 4 NPs for every 100,000. And in the United States, there are 40 NPs for every 100,000. While NPs have worked for many years in well-established primary care organizations like CHCs and family health teams, really the requests to access for care in novel deployments have really prompted NPs to move into this space. And so during my last rotation and consolidation as a nurse practitioner over 15 years ago, I had a wonderful opportunity to be precepted by an NP in Rosso, Ontario, named Donna Kearney. And she was a community member, and Rosso is actually just north of Barrie. And she really recognized a lack of primary care in her area. And so with the West Parry Sound Health Center, she set up the clinic in a trailer and worked with one other person who was a receptionist. And this is where I met Donna. And I was really blown away and really enamored by the work. And at the time, there were 3 other health clinics in the area, also called nursing stations. So funding announcements in 2018 allowed these 4 nursing stations with the West Parry Sound Health Center to apply and receive funding as a nurse practitioner-led clinic. And really for more than 50 years, communities in the West Parry Sound area have been supported by nursing stations to really meet the health needs of the rural community. And Donna really cared about her community. And as a community member, she really witnessed what the population was lacking. And as a result, the population was her profession. And I worked with Donna for 3 months and I loved it. And what I loved most was how I was proven wrong. Because what I thought was isolating and solo practice wasn't, because she had constant communication and consultation with physicians and other nurse practitioners and the other health stations and the community that she developed a really strong rapport with. So nurses have found themselves in innovative primary care positions really documented since the 1890s, when rural health posts were noted in Newfoundland and in the Northwest Territories. And indeed, in the 1970s, early 1970s, nurse practitioner rule became implemented through the recognition of universal access to healthcare, the fact that primary care was really being acknowledged and pushed at the time, and really an emphasis towards medical specialization and a perceived physician shortage. So I used the exemplar of Donna and the West Parry Sound Health Center to really demonstrate a model that uses NPs to their full scope and capability as independent interprofessional healthcare providers that provides care across the system. I'd like to take a moment to talk about the role of RNs in primary care. They are the largest group of healthcare professionals, but unfortunately, the role of RNs has really decreased in primary community care over recent years. And admittedly, nursing education programs have not focused so much on primary care education. I believe this is changing now, but they have been focused more in the past on prepping students for acute care environments. And the role of primary care nurses, unfortunately, is still unclear to many and underutilized, where we see RNs supporting triage, intake, scheduling, and prepping office tasks, like prepping an exam room, for example. But in Northern Canada, RNs have been working to a full scope for many years, which is similar to a nurse practitioner. And RN prescribing really could be seen as a method to increase access to care. And we use the success of England as a blueprint, speaking to our earlier conversations. And Ontario is the latest of 8 provinces to adopt RN prescribing, but the list is somewhat limited. And I really think we have to think about the evaluation and impact of this with multiple stakeholders to look at further opportunities. And really studies have shown that RNs and primary care teams improve patient satisfaction, health outcomes, and reduce physician workload. So how really do we address population health needs with RNs, offering a range of services across the healthcare lifespan that is co-managed with providers? So many believe, as I do, that the answer lies in team-based care. And the impact of team-based care really depends on every single provider practicing to the optimal scope. And this is the single thing that has the greatest potential to enhance provision of primary care across Canada. Yet primary care reforms have not described what a team is, what it should look like, how they should act, and what they should do. So I'll use the Crossroads Clinic as an exemplar, which is where I've been practicing as a nurse practitioner for the last 13 years. And it's a very special place, not only because of the patients that are served, because it's a refugee health clinic, but oh, it's not working. Thank you. Is this better? Yeah? No. Yeah? Okay. Thanks, Annie. Okay. So the Crossroads Clinic is a really special place because of the population that we serve, which is refugees, but also because of the work that we do. What was now 2 providers is now 13, and we've grown substantially, and we cannot do our work without really relying on the skills and capabilities of all of our staff, which include social workers, peer navigator, MDs, NPs, RPNs, and receptionists. We rely a lot on receptionists at our clinic. I have my own patient roster, and I'm the MRP. And in this setting of the Crossroads Clinic, we are constantly shifting our approach. We are very agile, and we really pride ourselves on that. I work to the full scope of my practice, and in the words of the Primary Care Action Plan, I support meaningful attachment. And many MPs do this or have the capability of doing this. And I think we really need to ask ourselves, why are NPs across the country working to their full scope in some clinics and not others? So what is really needed moving forward are time and resources to ensure that workflows are redirected and we engage team members. Hospitals and long-term care have done a very good job of this. We also need to tailor primary healthcare models to populations and think about the right mix of professionals to actually address the needs of patients served. This isn't a carbon copy. It's more like a menu of things that we can pull on and access like levers at different times. And moving towards team-based approaches really requires a culture shift. And this requires the inclusion of all healthcare professionals, including administrative staff, in policy and decision-making. We need to see this at all levels, including the regional health system level, at the macro level, where we can consider teams being at the center and not single professions. We need to build on the dual identity that health professions often hold. This is true, right? Where you can see yourself as a nurse or a doctor, for example, and an interprofessional team member. Yeah. So a fun fact, okay, nurses place a lot of importance on their role as central to effective interprofessional collaboration. This is really important, and I think we need to leverage this and harness this. We need to gain awareness of our personal, professional, and collective values, and this really does go beyond a list of selecting from clinic archetypes, how we advance primary healthcare. And in the role of academic settings, lastly, we need to think about how all providers are trained in interprofessional collaboration, communication and teamwork, and conflict resolution. And we also have to think about scopes of practice and how they overlap and complement each other. And this training must be centered in patient care journeys. We have to think about interfaculty collaboration in terms of simulation and problem-based learning, as well as inter-academic collaboration. So how great would it be to see colleges and universities collaborating, learning more about the role of a community health worker, for example? And intersectoral collaboration, so using institutions to really build and develop health and social care platforms to really engage in these conversations. And lastly, allowing new graduates to lead in this space and really lead in terms of what they are learning and how they can teach us in terms of interprofessional and team-based care. And having opportunities to really debrief and talk about how we see ours as our professional socialization and taught roles and what we've learned and how we can further digest this. So I'd really like to close in terms of saying that the way through this is with diversity of thought and opinion, and how grateful we are and how lucky we are to have each other and our colleagues and the patients that we learn from. And I look forward to the collaborative journey ahead.
Thank you, Vanessa. And I think anyone who knows me knows that I've asked this question of, we're building all these teams. We actually don't know how to run a team in a way to support attachment and retention. And this is a national, crisis, I would say, in terms of the lack of information. So our collective brains across academia, but also our professional associations, our community associations, each of us as clinicians on the ground needs to come together to help answer this, because the change is happening. So we have to, manage our existing teams and build new teams in a way that gets us to what Vanessa's talking about. So thank you. Brad, I'm going to turn to you now. We're going out west to Alberta. And Alberta's done a lot of work on primary care and organizing primary care, some of the leaders in the country around primary care networks, for example. And I wanted you to talk about how has Alberta done this? How have they built a more sustainable primary care system, and one that meets both rural and urban needs? And I think a couple of things, if you could touch on, would be some of the questions around, or some of the pieces around payment systems and payment models, private-public partnerships, if you could speak to that. So I know you were front and center with over a decade of change in Alberta. And of course, healthcare systems are always changing. Alberta is continuing to change, but tell us what you've learned.
Yeah, it's a tall task to talk about like 15 years of work in 5 minutes, but we'll do our best. So, I think if we were hitting some of the highlights around what some of the successes have been in Alberta. And I don't think we've cracked the nut on sustainability of primary care for everybody. There's a lot left to do, and we're under the same pressures, I think, that all the other provinces are right now. But some of the things that I felt were really important, the formation of primary care networks was actually a really important pillar for us that helped organize at one time what were really disparate practices who didn't talk to each other, didn't interact with each other, even though they were in the same geographic space. And formation of primary care networks and engagement of those clinicians were really a pillar of helping get primary care systems organized. And one of the important parts of that is we did pay good attention to governance and how those networks should be governed, and took a fairly standardized approach to what governance needed to look like, what governance training needed to look like, what engagement needed to look like. And originally, those were all independently governed. All the networks across the province were independently governed. And eventually that moved into a provincial governance system that's now laid the groundwork for something called Primary Care Alberta, which is now the fourth pillar, if you will, of Alberta's healthcare system that's now emerging. Another really important critical piece was leadership. So never underestimate what a small group of really engaged leaders can achieve. And I think we did a ton of work organizing healthcare leaders. Primary care is not a homogenous group. There are many different organizations within primary care. You have your college, you have your medical association, you have educational institutions. And we did a lot of work gathering those broad perspectives and putting pen to paper to say collectively what we think the future should look like. So bringing together leaders and having them commit to paper what the future should look like, and then using that to engage and develop relationships with your payer, your government, and also your healthcare system partners, which in Alberta was Alberta Health Services at the time. So that leadership work and organizational work really helped lay the groundwork for then official policy documents within government, like PCN evolution and framework document that set the stage for what PCNs need to evolve towards. And then most recently, something called MAPS, which is modernizing Alberta's primary healthcare system. Second pillar was leadership. Third is we really paid attention to the inertia of change. So we did have the largest change management team in the country, which I led. At one time, 60 to 80 people working on modernizing PCNs, modernizing primary care practices, developing and supporting leaders in communities, supporting approaches to change. And so an attention to the requirements of change management was another really critical piece of success for us in Alberta moving things forward. Right now, we are going through a transition, so there are also some challenges with primary care networks. So one of the challenges that emerged is some of the networks are quite small. Some of the networks are quite large, especially in rural Alberta. We have many quite small networks, and there's actually challenges on the large side, and there's challenges on the small side. And our colleague from the UK that talked about that magic, 150,000 or 50,000 segments that add up to 150 or 200,000 was really insightful, because that's exactly what we found in Alberta. There's a sweet spot there where you're big enough to have some economies of scale, but small enough that you still know the people that you're working and interacting with, and the leaders all know each other in that geographic space. So those networks are now moving into regional networks to deal with some of the challenges of silos that developed in areas because of the smallness of some PCNs, and also the inability to really take a geographic approach to care rather than a provider attachment approach to care. And so to be announced what that looks like, Liz, in the future, but that's a movement that's underway. Kind of backstopping all that is, how do you pay providers? What are the funding mechanisms to pay providers? And we do have some unique things in Alberta, some things that we've emulated now from other provinces. So I think what we've discovered is there's no one right way to pay clinicians. It just doesn't kind of work like that. Contexts are quite different. Availability of team can be quite different. And so we about 10 years ago started a blended capitation model, which works for a small group of practices, but honestly not for everybody. And most recently now, we've taken a page out of BC's playbook and have something called PCCM, which is a blended model, much like BC's, that incorporates hours of work, panel payment, and also a proportion of fee for service. And so, in fact, across Canada, you see this shift to blended payment models, some that are heavier on the capitation side, some that are heavier on the fee for service component, some that might be heavier on the hourly component, but you're seeing a blend of that really emerge everywhere in our country. And so it'll be interesting to see what the outcomes look like after the evaluation of some of these models, and does it deliver on the promise of transformation and actual clinical care delivery. Outside physician payment, we also have a nurse practitioner primary care model, which means that a nurse practitioner can open a primary care practice as the most responsible provider within Alberta. And relatively new program, but a growing program in Alberta. And you can either start a practice independently, or you may join an existing primary care practice in that model. We also have one of the largest scopes of practice for pharmacists in Alberta. And so one of the things that's emerged is actually pharmacy-led walk-in clinics or pharmacy-based primary care clinics. And again, there are challenges and there's pros and cons of all those approaches. But I think the current thinking is let's open broadly different avenues to access care, because access is really one of the biggest challenges that we have. On the flip side of that, when you fund different disciplines differently under different models, you can create some silos and overlap and inefficiency. And so one of the things we have to think about in the future is how we move to more collaborative payment models that allow for partnership around care. And then there's the rural problem. And again, this is a problem Canada-wide. How do you actually pay rural providers or incentivize rural-based care? And, like many other provinces in Alberta, we have top-up payments for rural providers. We have incentive programs for people that are going newly to communities. We have incentive programs for residents that are graduating to go into communities. And we're putting more education in rural spaces. So medical students under something called the Integrated ICC program. We now have a northern and we'll have a southern medical program or medical campus opening in part of our province. So we're moving those learners into those communities in hopes that that will then translate into more rural care. But one of the challenges is that when you talk about rural generalists, and so we heard about the cottage hospital idea from Sweden, and really in many parts of Canada, you actually have this cottage hospital model where you have rural generalists that are running a clinic, operating the emergency department, doing surgery and anesthesia, looking after all the inpatients, they're doing the palliative care. They are looking after people in long-term care or supportive living spaces. And I will say that I'm not sure we've quite nailed it in Alberta or anywhere on how do you need to modify or enhance or change some of the new payment models when you have somebody who works in so many spaces, requires a lot of skill acquisition and skill maintenance, and maybe in places where volumes in some of these programs are quite large or quite small. And I think there's still work to do to figure out how we adapt some of the emerging payment models in Alberta to really reflect the work of rural generalists, which is a much different job than family medicine in an urban setting. It is not the same job. And so we need to acknowledge that.
Excellent.
Thank you, Brad. And much to come back to. And I think, you, Vess, also mentioned the northern rural challenges in terms of the provision of care and just the fragility that is there. So, you're nodding as well down there, Nadia. So we're going to turn to you. I know that's a Canadian question about how to ensure fairness and equity for our northern and remote populations. But I'm going to have you talk about something which you mentioned in your introduction, which was around centralized patient navigation systems, centralized attachment registries, and what you've implemented in New Brunswick. It's always exciting when a whole province is able to do something digitally and make it work, and especially when it improves, I was talking about improving access and care for patients. So maybe you could walk us through how that worked, what the successes were, how you scaled it up. Feel free to mention the challenges and how you overcame those as well.
Thank you. So I read Dr. Danielle Martin's book, which is called Better Now. I'm sure many of you have read it. And one of her quotes in the books that really resonated with me was, as long as primary care remains outside of the healthcare system, it will struggle to achieve its maximum potential. And I think a very easy example of that is that, we can have the patient registry for all of the patients that haven't had their FIT test or their colon cancer screening, and we can identify all those high-risk individuals. But if we don't have pathways for them to access colonoscopies, we're going to remain outside of achieving our full potential. So I would say that our biggest successes at HealthLink have come from our ability to really be connected within the greater healthcare system, and that's also where our biggest challenges have occurred. So one of, I think, our biggest success stories has been because we knew that we weren't going to be able to have provider continuity, and it would be really team-based continuity. In New Brunswick, how it works when you order tests is patients go to the local hospital, or sometimes it'll be a clinic, but generally the hospital, to get their blood tests done. And that test comes back in a paper form to the individual provider's, nurse practitioner, physician's cubbyhole in the hospital. And so we knew that we couldn't rely on that to provide continuity. That would mean transferring papers back and forth. So we were able to work with both the regional health authorities and the Department of Health and what we call our EHR, which is our provincial health record, to have what we call an ordering provider, a single sort of ordering provider. So the tests are each ordered by an individual physician. We embedded transfer of care within our system. So the program was actually designed by someone who had been in emergency, like an emergency care physician. And so if you work in the ER, you transfer care at the end of shift all the time. So we thought, this is how we're going to allow for continuity of care. We're going to transfer care to the team, and then the team is going to transfer care to the next physician, which hopefully can be the same physician as often as possible, but not necessarily. So we, rather than the tests coming back to the individual physician and then being transferred to the team, and then the team triaging the results, we became recognized as an ordering provider, which means that the results came back directly to our team of nurses. And the team of nurses was really built up and was allowed to have medical directives that allow them to triage the results. So any critical result, obviously we have a physician or a nurse practitioner on call to review those critical results. But then all of the other results, if they're preventative, well, then the RNs are able to, our RN team is able to let the patient know and give them some education, some prevention. And then anything that requires urgent follow-up gets requested for an urgent follow-up in clinic. We have 10 clinics throughout the province in each of the health zones in New Brunswick. And so those in-person follow-ups are then sort of triaged by this central team. And that's how we've been able to build continuity of care for our patients, is through this centralized team and this core team of nurses, which has really been key to a lot of our successes. And this ability to really be connected, because we are sort of recognized as a team, it has allowed us to be connected to the healthcare system and have that agility, but also that ability to be to work with, as you said, really bringing all of these organizations in to really have the most connectedness as possible. And then I would say another one of our abilities to have success has been, I'm going to quote another book, which is Dr. Jane Philpott's book, Health for All. And one of her chapters, she talks about the cottage and having to renovate the cottage, and deciding at what point do you say, okay, the cottage, you can only do so much renovation. At one point, you have to rebuild the cottage and you have to kind of tear it down and build it back up. And really, we started from nothing. So we took over the patient registry, but there was no delivering of primary care for these unattached individuals. It was walk-in clinics or ER. Those were your options. So we were able to really build a program from the ground up, and having the ability to design something. Designing a house from the ground up versus renovating is completely different. And so I think that sometimes a lot of the time from a national perspective, it's sort of deciding, are we at the point of renovating, or do we just have to build something new from the ground up? And I think that's a big question for us all. And then the other thing that I will talk about will be our private-public partnership. So for those to kind of give context, HealthLink is a publicly funded program that is privately managed by Medavie Health Services. So patients receive care in a public clinic as they would in any other family physician's office, but it is managed through a private social enterprise, so not-for-profit organization. And I think that and I'm not going to say her name properly, so I'm just going to say the representative for Sweden said was that, a lot of the times it has a lot to do with the enterprise. And so I'm very fortunate to be part of an organization that is a social enterprise. And so it's not profit driven. It's about really equities embedded within the values. And I think that's something really important when you're looking at those partnerships, is what are those organizations' values. And to have an organization that is centered around the well-being of Canadians was very important. But obviously, one of the advantages beyond that was that when we talk about bringing in an IT team, having a human resources team, all of these elements that are necessary when you're building a system and when you're building change, were already embedded within our organization. And so I think that that's what has allowed us to have so much agility and to build rapidly in New Brunswick. And then with regard to the challenges, I mean, I think that the challenges have been, as I said, related to any time you think that maybe you've brought in everyone from the room to have a talk about something, you move forward and you're like, oops, like that group was not included, and then it causes you some struggles. So we had to kind of go back to, for example, the Nursing Association with regard to our notes and how our notes were embedded in our EMR, because the EMR is, as much as we talk about team-based care, it's the encounter is for one person and one person only. And so how do you build a nursing note within a physician note and having everyone's signature there and make sure that those regulations are respected? So I think that it's progress over perfection, definitely, that you have to take sort of as a view of it in a crisis. And when we talked about not letting a good crisis go to waste, I think that that's, the biggest thing. If you view it as a crisis, then you'll have a growth mindset. You won't have we have to get it right from the beginning. You'll know that you're gonna have to kind of take a step back to take another step forward, because you're gonna have that growth mindset. So I think that that's kind of been our reality.
Excellent. Thank you. So maybe I'll just put, and I will welcome questions. I'm going to just have a couple of probing general questions based on what I've heard some of you talk about. So whoever wants to jump in on this, please do. So I want to pick up on, and then the folks online here, you can bring your questions to mind, because I will turn to you in a moment. But one of the things we've talked a lot about this morning already is place-based care, geographic care, neighborhoods. So I'm wondering, and that's not how care has been provided for primary care. It's not been the focus of how we provided care. So I wondered if you could talk a little bit about how that's playing out in your jurisdiction and what you think some of the wins are and some of the challenges are as we move to that place-based neighborhood care. So I don't know who wants to jump in on what that's looking like in your jurisdiction.
I mean, I can talk about New Brunswick. So one example for us has been, I'm a rural physician, so I did that like ER, hospitalist, all of that work for 10 years in a very rural community. And one of our local Health Links clinics is actually in a building that was built as a co-op by the community, this rural community that's probably a couple thousand. And the community decided that they wanted to have the infrastructure to attract physicians from within. And so I think that when we talk about place-based care for us, when we've gone to different health zones and finding, you know, where is the clinic going to be and what's the best for the clinic and where can it be, it's been really identifying what's already there in the community, what can we build on, and then I think that from there you're able to maximize the potential of that community.
Good comment. Go ahead, Bob.
I mean, the move to the regional networks is really this is one of the fundamental problems I think we're trying to solve, Liz. And now, has that happened yet? No. Have they solved it yet? No. But I think that's something everybody is trying to solve. What we are seeing is really activation of communities and communities getting involved in how do you provide place-based care. And sometimes you have to be a bit innovative around, how you organize yourselves to deliver that care, what traditional models might look like versus what you have available in the communities. So, I can give you an example from my own practice. So, although my central practice is in Sylvan Lake, we're now operating a satellite clinic working in a hub and spoke model in a community that lost all their primary care. So we're doing that through a municipal-led initiative. The municipality is leading the clinic. We're kind of co-operating it with the municipality. The government has contributed some grant funding towards team-based care, in that particular setting. The health authority is helping by contributing some space for that model to operate within. We're partnered with the local private pharmacy and the pharmacist who's also delivering care in that community. And we're providing some on-site service in a mixture with virtual support and service for the on-site team that's placed in that community. So I think what you're seeing is models like that emerging that look at what are the needs of the community, what are the resources in that community, and how do we just be practical about organizing what we have to deliver care versus saying, this is the model that you have to work in. Well, that model doesn't work for me because I can't find an NP or I can't find an RN, but I can find a community support worker and a pharmacist. And so I think it's really, being flexible on how you do that.
And I'll give you the last word on this.
Yeah, I'd really agree. I think place-based care really takes it out of our domain and places it with the community and population where it needs to belong. And I really would love to shine a spotlight on the work of rural communities that are really having incredibly creative approaches here that I think we need to highlight, because often we think about the model and the gears that need to all come together. But I really think that there's opportunities to take it out of our domain and really think about what attachment means and let other people drive that conversation for place-based care.
Thank you.
I'll just quickly add to it, because I think it has to be led by these clinical models, but then, the way we create capacity and we enable this is the digital tools, whether it's virtual care or other digital tools that enable what has just been said. And I think the other one is tapping into that data, being able to understand what are those needs of the community through better understanding and accessing their local data helps to inform the clinical models that come out of it.
Yeah, excellent.
Question over here, and then over
happy to take some questions. So
here, Camille, I've got one here, and over there.
Hi, thank you so much. It's been wonderful. Camille Lemieux from UHN. So it's a question that probably doesn't have an answer, but I think in going back to the the notion that maybe we tear the house down and build it up again.
Yeah.
And that's in relation to EMRs. So it's extremely fragmented in Ontario, and more importantly, primary care EMR is disconnected completely from where the major EMRs are, which are in the hospitals. And I think it's a patient safety issue, it's a patient quality issue, it's many, many issues. And so I just would appreciate if you have any thoughts about trying to rebuild the the structure of EMR in Ontario. We have our Ontario health teams. We have hospitals often now who are moving towards the same EMR, at least in a region. In Toronto, it seems to be Epic. I think in other areas, it's Meditech. And leveraging our Ontario health team system to be able to bring together those hospital-led EMRs so that they become primary care friendly, they become integrated into primary care. It would help the emergency room so much. It would help with the specialist referrals so much. It would help avoid duplication of ordering and care. And more, I think most importantly for the purposes of the discussion today, it would make primary care's life much easier from an administrative, clinical care, and quality care perspective. I know it's a sort of a tall ask, but I would really appreciate the thoughts on that, because I think maybe we do have an opportunity now to begin to look at our EMR system and how it brings in primary care into a more cohesive mechanism rather than everybody having to go out and buy their own system.
Chris, I know I'd like to hear what you have to say. Maybe one of the other panelists where the EHR system looks a little different than it does in Ontario could speak to
yeah,
speak to that.
I can start. It's definitely an active conversation. The things you brought up are definitely being talked about in different pockets around the province. I think from our perspective, you know, we want to enable the primary care physician and clinician's voice into that conversation, understanding, I think, what is the value that can be achieved. I think we've seen some you know, logically, as you just said, some sharing of data, flow of the patients between primary care and specialists in hospital. There's a lot of opportunity. I think understanding the full value of that, cost implications, operational implications, who would hold that data, who would manage the operations of the EMR into the community. None of these are insurmountable, but they definitely illuminate some complexity that we need players around the table, including primary care doctors at that table, speaking to the university, the hospital infrastructure, and getting into how would this work and what is the implications of this. It's definitely, and there's some, you know, Kingston is a great example. Southern Ontario are starting to have these conversations, and I definitely think it needs to be something that's brought to the table, all the right players, and really look at that value for money, and then also look at it from a policy perspective at a province or jurisdiction. I'd be interested to hear kind of how it's playing out in other jurisdictions.
Well, I mean, there is some hope, so I can give you some hope. I'm not going to say we've solved the problem, but there's hope. So, I mean, one of the advantages we have is that all of acute care in Alberta has now moved over an 8-year period onto one enterprise system, but that's only acute care, right? Not primary care. So we still have the environment where we have many primary care EMR vendors. But in parallel to the hospital system, they created something called Community Information Integration and CPAR. So this actually pulls information and connects community EMRs to our provincial EHR, Alberta Netcare, meaning when you go to an emerge physician in Alberta, they can log on and see, well, this is Dr. Baylor's patient, and he saw Dr. Baylor a week ago for this problem. That's pulled in to the provincial viewer. That connection is also bidirectional, meaning when that patient hits an emerge, I get a notification. Patient's in emerge. I get the emerge note. When they're admitted, I get a notification. Patient's been admitted. Here's the admission history. When they're discharged, I get another notification, and here's the discharge summary. So we have pretty good connected interoperability now that's been built over a decade through focusing on that interoperable bidirectional communication. So it's up to about 80+% now of primary care docs are integrated in that fashion. So there is some hope. Now, a lot of the community-based EMRs still stink, just so you know, like they do everywhere. And one of the problems with this is actually information overload. So when you connect primary care docs in this way, all of a sudden you get a heck of a lot more information than you used to get. And now managing that information is an entirely new challenge. Before we were managing not having any information. Now sometimes we're managing having too much information.
Well, earlier we talked about what is the orthodoxy that we want to challenge, and one of the ones that I always go to is that I think that the patient should have their health chart. Like this is something that should belong to the patients. For those of you that don't know, Ontarians and people from out west have flooded New Brunswick in our rural communities. I'm joking, but since COVID, we've had a lot of, not really, but we've had a lot of people move over from Ontario because of the housing market, et cetera, and they come in expecting that I have their health chart or that I can request information for their health chart. This for patients, and from a patient perspective, this is the like they can imagine that we don't have access to this. And I think that if we want to build that nationally, maybe there's an opportunity to create a national patient chart that belongs to the patient, that moves with the patient. Because I don't think that we're going to have, we have students that go to other provinces to study, they come back home, they move to go back help their parents, and that information does not flow with them. Yeah. So if we're talking about tear down versus repairs, I think that there's one aspect which I think Alberta seems to have done really well, which is building those connections and building those renovations. But maybe there's also an opportunity for like a tear down just completely.
I'll just go to another question if that's okay. Okay, there's lots to be said coming about your question. So I'm going to move to a question over here. Go ahead. Yes.
Hi. My name is Lamo. As a fellow nurse practitioner, I'm really proud of Vanessa being here as a representation of nurse practitioner. I'm here representing RNAO, Registered Nurses Association of Ontario. And I want to congratulate the panel here for an amazing discussion, whether the topic is digital health transformation, whether it is team-based care, whether it is different payment models, or a centralized digital information, or EMR or EHR. I think the conversation around the room has been very vibrant, where we do realize that in Ontario, most of the funding is very hospital centric, like as already discussed. And so as primary care providers, when you have these EHRs, even within the primary care network, everyone has a different EMR system, which doesn't talk to each other. Forget about hospitals talking to primary care. So I think that's what creates the fragmentation of care and people slipping through the loops. And of course, there's a lot of screenings that are not being done. And with Canadian public health guidelines changing every now and then based on the evidences, I think as primary care providers, we are also not up to date. So it takes a lot for education, innovation, and research, evidence-based practice percolating down to frontline workers. I did want to ask about the payment model, because in Ontario, what we had was, when we talked about the long-term care sector, there was I don't know if the payment was like, the payment would go down to certain long-term cares that did not have complex comorbidities or alarming incidences or falls or whatever that may be. So if they performed well, it was very counterintuitive. Their payment went down. So I wonder, and for primary care, I think incentive is really key for people to work as rural generalists or people to work in rural communities. What is the insight into what kind of payment model you use for these initiatives?
Why don't you take that?
I mean, so in Alberta, the blended capitation model is risk adjusted, so it is complexity adjusted. But you are right in saying that if you make people less complex, then eventually you get paid less for them. So there's some truth to that. And that's played out in the US ACOs as well, as they've worked down the complexity and their payments have gone down. I don't know that that's a problem that's been solved, yet. And so even in our new model, PCCM, which is the blended model, the panel payment is risk adjusted. The panel payment portion of that is risk adjusted, but it will be, under the same limitation or the same problem as that. They also lag. So if somebody suddenly becomes complex, the kind of payment indicators lag behind, that. So there's challenges with some of those risk-adjusted payment models for sure.
So maybe if I'll take one from the audience. I've got one here as well. So coming to the end.
Or just a comment.
Yeah.
As a family doctor of 30 years, and I also, as mentioned, work as a rural generalist, but also work within the hospital, and so chief of family medicine and HHS. My experience in finding docs to work like I have comes in a challenge because there's not a lot of administrative supports for a lot of family doctors that I'm in the community. Like I lead a large family health team, so I have administrators and nurse practitioners and nurse educators and clinicians, but it takes a lot of administrative work on my end to navigate that. So it's difficult for doctors that work in a 2-doctor office to have AI because it took a lot to organize the process of how to do it. And then when it doesn't work, I'm like not able to see a patient because then I have to call AI scribe company to say, why isn't this working? So the infrastructure of support for the team-based model needs to start with the administrative support and the IT person that's there. Because when you're flying by the seat of your pants, whether you're a nurse practitioner, if I can speak on their behalf, work with them, or as a doctor, if something doesn't go right, you have to stop seeing your patients to deal with this. And no one wants to do that.
Exactly.
I want to do it.
Yeah.
And the other challenge with the IT aspect is, like, in Niagara, Hamilton Health Sciences Epic, down the road, they picked not Epic. And none of them talk. But the problem with Epic is that it is not great for family medicine because they download inboxes that are duplicate for our practice in our community. So all of my paperwork. So there's, you know, it's patient services, and docs still work on it and finding a way of supporting that so we can have our nurse practitioners, but then we don't have to administratively manage it. I know with the new funding, you know, with family health team, it's like, yeah, we'll give you money to build a family health team, but as family doctors, we have to build a family health team. That is really difficult.
Well, I could definitely echo. You're absolutely right. As I said, I think in my opening that, when it comes down to an IT problem or an EMR problem, the majority of the time it's the doctor having to remove themselves from clinical care and having to call up the company or pursue it on behalf of their clinic, and that is not sustainable. And I would 100% agree. If we want primary care to take a bigger and more significant position within our system, we have to invest in some core infrastructure. And from my perspective, I agree some of that core infrastructure needs to be IT, decision support, data support. That is, there's one number to call and your problem is dealt with. You're not having to hunt, okay, who's this one? I have to call this person or I have to call that person and then they don't get back to me. Like that needs to be just like, again, I'll talk about infrastructure that is at a hospital level. If a doctor has they call an IT help desk and it's dealt with straight away. That's, we need to get to that level. And it's something that we're exploring in Ontario, is to be very responsive to physician and clinician needs so that we can give them that type of digital support.
So we've come to the end. I am going to turn to our panelists for a sentence on, you're at the end of listening to this group and each other. Where is your head gone to? The thing you're most optimistic now about, or where you feel you're going to put your energies in your part of the country? So give that to me in a sentence.
I'm really interesting, both the international and learning here, maybe just on the same comment I just said, building up some infrastructure to support primary care and making sure that that infrastructure is responsive to what nurse practitioners and physicians need to deliver care, whether it's from an IT perspective or administrative perspective or clinical flow perspective. I think that's there. And I think if you have that infrastructure and you have physician and clinician engagement, the power of some of the new technology that we know is on the horizon, I think, can really be a real changer. But it can't be done unless we have some core infrastructure within primary care.
Go ahead, Vanessa.
Yeah, Crystal, leverage off what you're saying. I really think that in research, it shows that teams that are fluid, like primary care, they often have a harder time seeing themselves as a team and creating that mindset, because it's really built around the patient care journey, which can be so variable. So I think there's an opportunity here that everything new that comes our way, we have to harness and create it based on the patient population and use it as an opportunity to build a platform. How wonderful would it be to use digital infrastructure to think, who's not in this circle? Oh, it's community health workers.
Right.
Let's bring them in. Let's create a platform that actually establishes that. So we're using it as an opportunity to rebuild.
I mean, the reason that I still do this work is I'm passionate about creating great places for clinicians to work and love their work doing it. And I think a lot of the things we've talked about are ingredients to that puzzle. It's just about putting it together in a way that achieves that in the future.
So I will end with a quote because that's been my theme. But systems are perfectly designed to produce the results that they produce. So I think if we have a disconnected primary care system and environment, it's because we've designed it that way. So I think we should be very, very thoughtful about how we're going to design a primary care system if we indeed want a system. And then the other thing I'll say was, I forget your name, but when you were talking about the metrics, and I read somewhere, and I might be messing up this quote, but it says something about how when you start measuring a metric, it loses its value. So if people know that you're doing a risk-based or elderly population has a certain value to their capitation, then you're going to lose its value. Whereas when you use metrics for growth, it's going to have a very different impact. So I think being very, very thoughtful about when we're designing something and we're going to use a metric for performance, what impact that's going to have on the system.
Perfect. So I want to take this opportunity, firstly, just to thank our panelists for digging into what's happening and being honest about the opportunities and challenges in primary care in each of their jurisdictions. So a huge thank you to them. And I want to thank all of you and everybody online. This is a moment in time for primary care. I think with intentionality, and I dare say intensity, we need to drive to not just making a team or making the EMR a little better, or this is not a tweak around the edges moment. We are truly building a primary care system. We are a one nation with 13 healthcare systems, but I think for Deloitte to bring us together and talk about how can we learn from each other to accelerate what we're doing in each of our jurisdictions is really a great opportunity. So looking forward to this afternoon's conversation as we drive more into the opportunities for change, and handing it back to you for closure.
Awesome. Thank you, Liz, so much for moderating, and all of you for your participation. I think it was great to take it from some of the more international ideas that came out of earlier this morning into some of the tactics of how do we get things done in this country. And I think all of you said it so well in terms of let's think transformative. Let's think about how we can really kind of, as Tom alluded to at the beginning, use this crisis to move things forward, and like how that balance with, what are some of the really tactical and practical considerations that we need to have on the ground as well. So with that, we will close out for everybody online. So thank you so much for joining us, and hopefully you've all taken something out of today. I really appreciate all of your time online today. So with that, we'll close out our online,